Hi, my name is Mike Pishfine. I'm a GI medical oncologist at Johns Hopkins University, and it's my pleasure to be a moderator here for a GI Oncology Tumor Board. And I'd like to go around and introduce the panel. I'll start with Dr. Zev Weinberg from UCLA.
Hi, my name is Dr. Zev Weinberg. I am a GI medical oncologist at UCLA, Los Angeles, California. Nice to be here.
And then from Emory, Dr. Pritesh Patel.
Hello, Pritesh Patel, Associate Professor of Radiation Oncology, GI Radiation Oncology at Emory.
From Memorial Sloan Kettering, Dr. Martin Weiser.
Hi, I'm Dr. Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
And finally, from Washington University in St. Louis, Dr. Carrie Siegel.
Hello, my name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Well, thank you all for joining us. It's going to be some very interesting discussion about some exceptional cases, and I think we should go ahead and dive right into it. This is a 42-year-old Pakistani male with a history of small bowel neuroendocrine tumor and who underwent a resection in 2014, but now has unfortunately recurrent metastatic disease with a gallium-68 DOTATATE PET scan showing multiple liver lesions, and as well as abdominal adenopathy and a possible bony lesion, although the liver biopsy was negative. So what are the next steps for diagnosis and what would be the recommendations for treatment? So this patient initially presented with recurrent and intermittent abdominal pain, good performance status at that point. The patient didn't have any significant medical history and really no social or family history that impacted the care at all. The patient had a colonoscopy in July 2014 that was normal, but a CT scan showed thickened and matted bowel loops in the right iliac fossa, causing luminal narrowing. The patient underwent a resection of the ileum and cecum with a right hemicolectomy, the pathology of which revealed a well-differentiated neuroendocrine tumor of the ileum, 2.5 centimeters in size, with the tumor infiltrating through the muscularis propria into the subserosal fat with negative margins, although 1 out of 10 lymph nodes were involved. There was also extranodal extension with perineural and lymphovascular invasion present. A CT scan of the chest, abdomen, and pelvis at that time showed multiple small bowel loops, matted small bowel loops in the right iliac fossa, but likely secondary to postoperative adhesions, but no obvious metastatic disease. But then unfortunately, the patient presented in September 2019 with mild interval increase in one mesenteric nodule, which was biopsied in October 2019 and did show the same metastatic neuroendocrine tumor grade 2. So before I move on here, let me take a quick pause and talk about the two pathologic specimens that were removed. Dr. Siegel and Dr. Weiser, the case was initially diagnosed in 2014, but now, do you consider gallium-68 DOTATATE PET scans to be a standard part of the evaluation for a potentially resectable neuroendocrine tumor?
It's certainly done very frequently. I don't know that it's done on all patients. Some patients will have abdominal and pelvic MR, and some will have that with a somatostatin DOTATATE PET. But I don't know that all patients are getting DOTATATE PET. I don't really have a really good understanding across the country how accessible this is for all patients.
Yeah, I would agree. If there were questionable lesions you needed to characterize, I think that would be a very good indication. However, a presentation of a primary ileal lesion with lymph nodes, I wouldn't necessarily get the scan before surgery.
Gotcha. Dr. Weinberg, we don't have any of the pathologic details such as Ki-67 or mitotic index, but are there any circumstances under which you would have given adjuvant therapy in 2014? And perhaps, for example, in an incidentally resected high-grade neuroendocrine tumor?
So in this specific case, I mean, we see that it's a well-differentiated neuroendocrine carcinoid, and there's no real role for adjuvant therapy at all, as we all know. This is a perfect example of perhaps why there's no role, because the disease behaves often very indolently, and there's no clear benefit for any adjuvant therapy. Even, in my opinion, in a high-grade neuroendocrine tumor, there's really no data to support adjuvant therapy in that context. Certainly prognostically, it's much worse and has a tendency to recur much sooner. But I would not automatically do adjuvant therapy in that context as well. There's no real survival advantage, let alone progression-free survival advantage.
Got you. Okay. So continuing on here, so we're not sure what the gap of time was for this patient, but in January 2021, they had another DOTATATE PET scan showing multifocal hepatic lesions with abdominal lymphadenopathy. But in this case, the liver biopsy was negative for malignancy. Now, remember, just 12 months prior, they actually had a mesenteric nodule that was positive for the metastatic neuroendocrine tumor.
You can see three separate images here from our somatostatin imaging, our DOTATATE PET. There's a I'm guessing about a 1.5 centimeter lesion high up in the liver. There's a DOTATATE avid rib lesion on the right, and there's a fairly sizable lesion that's DOTATATE avid directly anterior to the IVC. Of the three lesions, this mesenteric nodule anterior to the IVC appears to be the biggest and the most robust in terms of the somatostatin, the DOTATATE avidity. So if we were going to discuss biopsy of any of these three lesions, the liver lesion is fairly small. And just because something is avid on a somatostatin PET CT or even an FDG PET does not mean that we can see it on an ultrasound or a CT. That's problem number one. Problem number two, the lesion is fairly small and very close to the liver edge. And lesions that are high up on the liver either require us to start down below subcostal and angle quite a bit cephalad to do a liver biopsy, or go intercostal. And these have a lot of, there's a lot of this can be varied based on the patient's ability to hold their breath, since the whole lesion's only about 15 millimeters. Whereas the mesenteric lesion's a little bigger. Now, one might say, well, the mesenteric lesion's fairly deep. It is, but a lot of times when we're doing ultrasound guidance, we can take the transducer and kind of compress it into the patient's abdomen and take a lesion that's 6 centimeters from the anterior abdominal wall. And by the time we're biopsying, it is only 4 centimeters, because we're sort of squishing in and decreasing that distance. The rib lesion looks a little tiny. Luckily, that would be done by my MSK colleagues, not myself. That would be tough. A lot of times in a situation like this, the medical oncologist or the surgeon will just call us and say, I'd really like the liver, but if you feel it's safer or easier, you can get more tissue with the mesenteric mass, go for the mesenteric mass. Usually there's a little bit of a discussion. Sometimes we'll bring the patient without even identified in advance whether we're going to do the liver or the mesenteric mass, and look under ultrasound or CT and see what kind of conspicuity we have with the liver lesion.
Gotcha. Thank you. Actually, I wanted to ask you to sort of just wax philosophic and how GA-68 DOTATATE PET scans have really changed the overall picture for neuroendocrine tumors, at least compared to prior octreotide scans. I think on the medical oncology side, we've had some pretty, dramatic experiences, but I don't know from the radiologic side what you all have experienced.
I think it's been a game changer. Really, it has. Yeah. And also the follow-up imaging with the MR, both, because those little tiny nodules tend to really sort of light up on the diffusion imaging. So I think both have really been really remarkable in terms of our ability to do a much better job at a clearly sub-centimeter level.
All right, very good. So I think that we had a great discussion. Thank you, Dr. Siegel, about the complexities of getting a liver biopsy. So we'll skip that question. And again, we did have a positive mesenteric biopsy. But under what conditions then would you consider treating this patient without a diagnosis? But again, I think we do have a diagnosis. Do you feel compelled, Dr. Weinberg, to get another diagnosis of the liver lesions?
Sorry, were you asking me or Dr. Weiser?
Dr. Weinberg.
I mean, okay. So no, I mean, I think that we all know that biopsies can be false negatives, and
Right.
I think that as Dr. Siegel mentioned, it's not necessarily so simple to do a biopsy. We have documented evidence of metastatic disease based on the mesenteric nodule, so I personally don't see an absolute role to repeating that liver biopsy again.
Gotcha. All right, Dr. Weiser and Dr. Patel, which patients would you potentially consider for local therapy? So paint a picture of the kinds of patients that both of you would consider for local therapy, be it surgery, SBRT, or other local therapy techniques. Either one, Dr. Weiser?
So you mean liver resection for isolated disease? It is quite tricky. We do like a long disease-free interval, as we talked about, which we usually have for the carcinoids. Isolated disease, I think, as we mentioned, it's a very good indication for MRI and or DOTATATE. Those are the best imaging in this case. So for very obviously isolated lesions, we would consider it.
Dr. Patel?
Yeah, I would concur. I think that's critical. Just also in the, where the local therapy fits into the overall journey for the patient. Is this local therapy going to avoid a change in systemic therapy or avoid initiation of systemic therapy or something like this? That might be a reasonable indication. As it relates to radiation, I think there is some consideration about the grade of the tumor. So, the very sort of indolent, slow-growing grade 1 tumors, their radiosensitivity really is somewhat unknown. We don't have a lot of data to guide us here. So, we know we have a good effect on more rapidly proliferating tumors, but the very indolent tumors, I think it's somewhat unknown. So if we were entertaining SBRT, for example, I'd really want a location where I'm confident I'm going to be able to give the full and high dose without compromising at all, particularly in tumors that might be a lower grade.
Gotcha. And then Dr. Weinberg, what would be your systemic therapy choices, both for initial first-line treatment and even subsequent lines of treatment?
Well, I mean, generally speaking, I'm not sure I would initiate systemic therapy on this particular patient. This is, as you've heard, a very common and controversial area. This patient has very low volume disease at this point. And the question should be asked is whether the patient can have local therapy done on these isolated areas, which would essentially substitute for any systemic therapy at this time. In patients that have more systemic disease, we typically start with an SSA, as you know, with either lanreotide or somatostatin, which are both essentially approved for this situation, and themselves have, at least in the case of lanreotide, a proven survival advantage, but somatostatin to some extent may as well. Certainly a PFS advantage in any all-comer, well-differentiated neuroendocrine tumor. But the problem with that therapy is, of course, it's relatively open-ended, and in a patient with very low volume disease, in whom you're going to start that disease therapy, I'm often not sure it's the right thing to do in a context like this one. There's very little data to guide us, actually, because they were included in that study, but we try to avoid starting too much systemic therapy too soon in this kind of patient.
Yeah, that makes sense. And then, so let's say this patient progresses on somatostatin analogs. What would be your next choice? And actually, what I really want to specifically ask you is, are there circumstances under which you would delay lutetium-177 treatment?
Yeah, so I mean, lutetium-177 has been a game changer in this disease. I think the data is very compelling. It's focused. It's limited, so it doesn't have to be terribly prolonged. And certainly in patients that have progression on an SSA analog, that would be the optimal treatment of choice from a systemic therapy perspective.
But would you be concerned if you had a 35-year-old with progressive disease on lanreotide?
Oh yeah, if the 35-year-old had progressive disease, I would try to get them on lutetium as soon as possible, actually, because as you know, the survival advantage is quite compelling, and there's a clear benefit, long-term benefit even, as early data have suggested, to initiate lutetium therapy sooner rather than later in those patients.
Gotcha, very good. All right. Well, this was great. I think the panel overall was recommending that there's really probably not a clear need for a liver biopsy, especially with that mesenteric biopsy having proven recurrent metastatic disease. We definitely emphasize that local therapy plays a role, be it surgical metastasectomies or radiation or other ablative techniques, especially if it's going to delay the patient having to start systemic therapy of any kind. The standard systemic therapy, well, one therapy would be potentially to just watch and wait, but another one would be to start a somatostatin analog. And then in second-line therapy, the current standard is lutetium-177 DOTATATE therapy, which unfortunately is not widely available, but hopefully it will become more and more available.